We'll start off with Dr. Eames. He's going to talk a little bit about addictions and that particular certificate program, and then we'll just go through the 5 specializations or the 5 certificates that we have, and then I'll make some concluding comments. So, Kevin, you want to come on up?
Hi. Am I good? Can you all hear me? Okay, am I lighting up somewhere? I teach the addictions counseling course in the summer here at Richmont in Chattanooga. And I start off, I didn't put this in my slideshow, but I start off by quoting from my favorite theologian, George Carlin. Anybody ever heard of George Carlin? At one point in the 70s, George Carlin was known for telling jokes about drugs. And one of the things he said was really very profound. He said, he's sort of describing the first person. I don't suppose he meant Adam. It was just, he just said it was the first guy. And he said he looked around and he said, this can't be it. And so when we start talking about addiction, we recognize that there's a sense in which that a person's attraction to a substance of abuse is not just about an excessive amount of dopamine in the nucleus accumbens, but it really is about making an attempt to fill something that they otherwise can't fill, something that Pascal might have called a God-shaped vacuum. So we begin with that recognition that human beings are fundamentally in need of something, and that one of the ways that they attempt to make that filled is through addictive substances or addictive behaviors. And so we begin that discussion. But the model that we use when we talk about how do you work with an addicted client, we're going to look at a couple of examples. I'm not going to read this whole thing to you because it's too small, but I'll basically say that, and these are both taken from one of the texts that we use, a book by Connors and DiClemente. There are a couple of case studies in here that I'll be referring to. And this is about a man who is having some trouble with drinking. And the reason that he claims that he's drinking is because his wife bugs him. And so, and so if his wife would stop bugging him, he said, maybe he would be able to give up the alcohol. But until that time, he's got to figure out a way to deal with his stress. That's kind of the gist of it for him. Now, Bill F. is another client who, after a weekend of some alarming alcohol use, has come to the conclusion that maybe he's an alcoholic. The problem that he's having, that he'll be discussing with his therapist, is his wife isn't really all that excited about the idea that maybe he's going to be he's an alcoholic, and what's that going to do to their social life? So in both of these instances, we've got people that are at 2 different places in terms of thinking about their problem and thinking about how ready are they to change. And so the gist of what we would attempt to do is to increase the pros of change and decrease the cons of change until we reach that sort of tipping point. There would be a tipping point, and for each individual it's different, where Armand or Bill would decide it's time to make a plan and it's time to take action to make a change. I think we could safely say that Armand is further away from that tipping point than Bill is. But the point is that we want to facilitate that movement to a decisional balance where they are ready to take action. So we're going to talk about the stages of change This is the model that we use. This is actually a very well-researched and evidence-based model that has been used not just with alcohol, but with lots and lots of problematic behaviors like smoking and diabetes management and health and cardiac. But the 5 stages, and I won't go into all of the cells here, but is pre-contemplation. This is where the person is not thinking about changing. Contemplation, where the person is thinking, but sort of the key characteristic is ambivalence. That pro-con balance is kind of tipping back and forth. And then once that ambivalence has been resolved enough for the person to begin thinking, maybe I really do need to make a change, they begin preparing, and then they go ahead and take that step. Now, what's interesting about this model is you don't really see evidence that a person is changing until the 4th stage, when they actually implement their behavioral plan. This may be the first time that they go to 12-step, the first time they enter treatment. So there's been sort of this long process that's led up to this. And then finally, after 3 to 6 months of being in this action stage, they begin to maintain a set of healthier alternative attitudes and behaviors that can replace the maladaptive behaviors that they've been using before. The word stage is a little bit deceptive. We tend to think that stages begin and end at a very precise time. Tonight I'm going to end the preparation stage. When I wake up tomorrow, I'll be in action stage. They tend to be a little bit more fluid. So the point is that we try to get people to move cyclically from one part of the stage to the other. And one of the nice things about this model is it allows for re-education. A person may go through the stages. They may then, what we might call relapse, but in reality, it's an opportunity for more learning. Maybe we weren't really ready to change as we thought we were. So for Armand, we would identify him as being in the pre-contemplation stage. And our goal as counselors is to move him or to help facilitate the movement. A lot of times you can't push people, you can't move them. They have to sort of be willing to move themselves, to help him recognize the need for change. Now, Bill, on the other hand, we know he's in the contemplation stage. He's thinking about the fact that he might be an alcoholic. He's recognizing that there are problems with his behavior and with his patterns of substance use. And so what's present for him is ambivalence. And Bill's wife is going to be very much a key factor in terms of his ambivalence. She might be, for whatever reason, tending to minimize. And this is an opportunity where you can bring in some marriage and family therapy, maybe some systems interventions that can address the power dynamics in the relationship. The nice thing about this stages of change model is it's trans-theoretical, which means there's not one particular theory of counseling. You can use a lot of different approaches. It's not one theory, but multiple theories that can be used to help move people from one stage to the next stage. So how do we facilitate that stage progression? This is one of the things we talk about. We actually do some role-playing. We increase awareness of problems with the behavior. We increase emotional arousal. Now, that doesn't mean we make the client cry about it, but although that's not a bad thing necessarily, but we get them to acknowledge some affective result from their behavior, how it might be violating their own values, it might be hurting their wife or children or husband, and then to talk about how good it would feel to think about a life apart from the substance, to be having an identity apart from being a substance abuser. And also recognizing how does this affect the social environment? How often does the spouse have to call and make excuses because the person has indulged too much? Thinking about a person's identity. When a person is very much invested in substance abuse or other kinds of behavioral addiction, it's very much a part of their identity. This is who I am. It's not healthy. And so to begin to imagine what would life be like with me being free of this addiction. And so the therapist who acknowledges the autonomy and self-efficacy of the client encourages the belief in the possibility of change, that change is possible and that there can be hope for the person if they themselves are motivated to change. One of the most successful ways of approaching moving people through these stages is called motivational interviewing. Motivational interviewing is not the same as the stages of change, but they're very much complementary. And it's a type of person-centered conversational style or counseling style that, even though it's person-centered, it's very different. It is more directive, it's more focused, and it's about addressing the common problem of ambivalence about change. Now, if you think about the last time you had to make a big change, the last time you said, I'm going to give up Mexican food or something, how ambivalent would you feel about that? Walking in, seeing this lovely spread, that would be really difficult. And so there's lots of thinking and discussion and trying to determine how do I get engaged in this process of change. One thing that's nice about motivational interviewing is that it does encourage babies to lift weights and join CrossFit. I'd like to say this is a photograph of my youngest daughter, but she's 17, but is an advocate of CrossFit, and I'm not sure where she got it, but a lot of the models that we use in approaching counseling tend to be deficit-based. In other words, we, the counselor, come in and we say, we are going to fix you. And sometimes that's necessary. Sometimes people need the expertise, sometimes education, sometimes understanding what skills are missing. But motivational interviewing is not a deficit-based approach. It's a strength-based approach, and it's predicated on the idea that the counselor gets with the client and says, let's harness whatever strengths that you have and marshal those strengths to allow you to give up this addiction or make whatever change that you would want to change. So some principles: express empathy using reflective listening. This is what they'll initially teach you. You've probably already had exposure to sort of interpersonal, what I hear you saying is, and then, but then in that listening, you are listening for discrepancies between the client's goals and their values and what they're doing, the behavior. So you say that you believe this, but yet you're doing this. And these are things that the client is both saying, so you want to be sure, you wouldn't want to do that confrontationally, but just to be able to point that out. Rolling with client resistance. I think there's perhaps nobody here, but I think there's this general idea that an intervention means you yell at somebody. You put them in a chair and you act like Dr. Phil. And that's not the model of motivational interviewing. If a client is resistant, the assumption is they have a reason. It's not your place to try to argue them, because then who has the power? But change strategies, roll with resistance, and then acknowledge and support self-efficacy. It gives the client their own sense of responsibility for making this change. They're making the change. They have to live with the consequences and not you. So 4 ways of moving through this: engaging, focusing, evoking, and planning. And if you can sort of think about how this works with the stages of change. In fact, there we have it. We see engaging and focusing as being part of the pre-contemplation stage. Excuse me. Once they have acknowledged the ambivalence, then encouraging them to think about the discrepancy between values and behavior, and then hopefully getting them to a place of preparing to take action. Now, these were two different, and I didn't want to go through and read everything. I purposely put too much on the slide, so it will make you want to come back and learn more. But the same process can be used. It's a framework where certain types of interventions, not only does motivational interviewing effective, but cognitive therapy, behavioral therapy, acceptance and commitment therapy, these are all valid ways of helping people to move through these stages of change. So here are the works cited, and I think I came in under 20 minutes, but I'm not sure. But
Any questions for Dr. Eames? About the addictions?
Sir?
What are
The courses. You know, Dr. Doverspike sent us a slide, and I'm not sure that I can give you the exact prefixes. There's addiction counseling. I think there is an eating disorders course. Dr. Bradshaw, aren't you going to go over this at some point later, or
Well, not
specifically?
check, but
Okay.
per track, but I mean, we will talk a little bit about some of that. Yeah.
Okay, I think somebody has them over here.
As eating disorders, psychopharmacology, and then one course on sexual addiction, and
Right.
one course on sexual dysfunction. So, right now. But the addictions class itself that Dr. Eames is referring to, everybody in the core takes that. And then you can specialize in that too, if you want to.
We spend the first half of the course talking about the biophysiology of addiction, and then this, not quite the whole first half, but we devote some time to understanding how the brain works, which we think is helpful in helping clients recognize this is more than just a character issue. But then we spend a good bit of the time talking about interventions and doing counseling and going over case studies and so forth and so on. So thank you for your attention. I will yield my microphone to some other person.
Thank you.